Hello, everyone. This is Dr. Nicholas Butler with APMA. I'm the young physician member, part of the Communication Committee. I am from Cleveland, Ohio. I work at Kent State University College of Podiatric Medicine, as well as in private practice in Beechwood, Ohio for Erie Foot and Ankle Centers. Today on the call, we have Dr. Simpson, and I'll let him introduce himself as well.
Well, thank you, Nick. My name is Dr. David Simpson. I am a neurologist. My place of work is the Icahn School of Medicine at Mount Sinai in Manhattan in New York City. My titles there are Professor of Neurology, and I'm Director of the Neuromuscular Disorders Division and Director of the EMG and Clinical Neurophysiology Laboratories. I have a long-standing interest in peripheral neuropathy, both in terms of clinical care as well as clinical research, particularly dealing with the pain associated with peripheral neuropathy, such as diabetic neuropathy. And it's a pleasure to be here with you today. So I'll turn it back over to Nick.
Thanks, Doctor. I really appreciate you being on the call with us today. The question I want to start off with is, what neurological symptoms should a patient with diabetes watch for in their feet?
Well, it's a very important question because patients are the first ones to know and to recognize that they may have a symptom, a problem that may be due to neuropathy. And the symptoms can be varied. One of the most common symptoms of neuropathy affects sensation of the feet. So, for example, patients may have numbness or tingling or pins and needle sensation. What I often tell patients is everyone's experienced their foot falling asleep, such as when you cross your legs in a movie theater and you get that strange tingling in the feet. That kind of symptom can occur in patients with diabetes, but persist. And the symptom could be mild and just barely noticeable, or it can get severe and actually quite painful. And the pain could be so bad that patients sometimes say they feel like there's a lit match or a fire burning their feet. They may have difficulty putting on shoes and socks because the pain is so great. And that pain, burning, tingling, and numbness can later affect the hands. So those are some of the early and most important symptoms that patients with neuropathy should be aware of.
Okay, kind of rolling into that question, if the patient with diabetes begins experiencing those pain and discomfort in their feet, what should they do?
Well, the first thing they should do is look at their feet. And podiatrists, of course, are looking at feet all the time. And I always recommend to my patients with diabetes that they have good, regular follow-up care with a podiatrist to inspect the feet, not only the top, but the bottom. And if they can't turn their feet over to look at the bottom, there are mirrors available and other devices that they can use to inspect the bottoms of the feet. And the reason that's so important is because diabetics who may have numbness in the feet may not even be aware that they have a cut, a bruise, an ulcer, or some other abnormality that they may or may not be aware of. And that certainly needs attention. So inspection, care with podiatrists is very important. Now, in addition, if patients with diabetes have these symptoms of numbness, tingling, burning in the feet, not only should they see their podiatrists, but they should discuss it with their primary physician, their family doctor, their internal medicine physician, and let them have a look at the feet and see what they can figure out. Ultimately, if there's a neuropathy problem that requires more advanced consultation and care, then the internist may send them to a neurologist like me. They may send them to a pain management physician to provide further consultation, including proper diagnosis and care, because there are other causes of feet pain in diabetics above and beyond neuropathy. So one has to make the right diagnosis.
Yeah, I think that's a great point, especially, with my patients. Sometimes they are with their primary care doctor, and I'm saying maybe they need a little more help getting them to a neurologist, maybe get them to a endocrinologist to get their diabetes a little bit more under control. I think that's a great point. It's a team effort. It's not just one of us it's kind of all of us together.
Absolutely. The team effort is a key point because every healthcare provider brings their own set of skills to the patient. The podiatrist, the internist, the family care doctor, the endocrinologist to control the blood sugars properly, the neurologist, the pain management doctor. Everybody may have something to contribute, and depending on the patient's individual problem, one or more of these doctors can help to both diagnose it properly and then to treat it properly and prevent it from getting worse.
When you diagnose a patient with diabetes, with peripheral neuropathy specifically, what do you want them to know or understand?
Well, the first and most important point is the patient and their family and healthcare assistants are their best advocates. That is, the patient should advocate for themselves. And even if their internal medicine or family care doctor says, you've got a little neuropathy, don't worry about it, and just live with it, that's not enough. There are things that can be done to both diagnose the neuropathy properly and then to treat it properly. Now, once the patient finds the right provider, including any of the doctors we've mentioned earlier, then they need to follow through with the recommendations as to what needs to be done. Again, one of my roles is diagnosis. So when I see a diabetic patient with pain in the feet, I need to know, is this neuropathy? Is it gout? Is it plantar fasciitis? Is it arthritis? Is it vascular disease with circulatory problems and arterial insufficiency? All of these things can cause pain in the feet. And unless we make the right diagnosis, we're not going to be able to treat it properly.
That's a great point. When it comes to what are some of the potential outcomes of peripheral neuropathy, and why should this condition be cause for concern for our patients?
Well, although peripheral neuropathy doesn't kill you, it certainly has a major impact on quality of life. And anybody who's experienced pain knows that when pain becomes chronic, imagine someone having a lit match to your foot 24 hours a day, 7 days a week. That is a miserable quality of life. And patients don't need to accept that. They don't need to say, I have to live with this pain. There are treatments available, not to mention protection of the feet. If a patient develops an ulcer, if they develop an infection, if they have nail disease, in diabetics, all of these things are magnified. And again, patients need to recognize that all these things can be treated and their quality of life can be improved. And if they talk to their doctor about it, their family doctor or internist, and they either don't have the time, the interest, or the skills to deal with it, they need to tell their doctor, or the patient needs to find for themselves another provider that will deal with it.
And as a neurologist, how do you and podiatrists typically collaborate on these conditions?
Well, I work very closely with my podiatry colleagues. We have a wonderful division at Mount Sinai. I work with many outside podiatrists, and I lecture, for example, at the New York School of Podiatry up in East Harlem. And I, for many years, have found a very successful collaboration with podiatry because they're often the front line. That is, the patients may come to the podiatrist with diabetes and with problems of their feet, including neuropathy. And the podiatrist may recognize, and hopefully will recognize, that this is a problem for which I can use some collaboration with another physician, like a neurologist like me. And we work together with these patients, both contributing our knowledge and skills to improve that patient's condition.
As a neurologist, what are some options for treating painful peripheral neuropathy for our patients? What are some of the latest developments that you've seen that possibly that you're starting to use in your practice nowadays that you weren't using maybe 10, 15 years ago?
Sure. Well, again, it starts with the correct diagnosis. And unfortunately, I've seen many patients who have been diagnosed with one disorder in which they have something entirely different. Some patients who have pain in their feet, and it's not even clear what the cause of the pain is, we may do some testing in our laboratories. We may do EMG studies with nerve conduction and EMG, where we can test the nerves electrically. We may even do skin biopsy of the leg to diagnose a problem called small fiber neuropathy, which is not well recognized by many in the community, but a very important diagnosis and common in patients with diabetes. Once we have the diagnosis, then we discuss treatment. And we've talked about proper foot care, including follow-up with a podiatrist. Then we have treatment, particularly the treatment of the pain. Now, how do we treat? Well, some patients may require physical therapy and occupational therapy to optimize and help them adapt to their condition. Some may require proper footwear. The podiatrist often can help with that with custom orthotics or custom shoes. Pain management is where we've seen a lot of advances.
I think that's one of the things that, a lot of our patients are always trying to figure out, is there a treatment for this, or do I have to live with this for the rest of my life? I think that's always a huge question that I get personally a lot as a podiatrist. And sometimes, it's a tough question for me to answer specifically to give them, a exact answer. Is there anything that you could give patients if they ever ask you that question? Do I have to live with this for the rest of my life?
Sure. Well, I'm asked that question all the time. And the short answer is no. You do not need to live with this for the rest of your life with the degree of pain that you're experiencing. Now, the second thing I say to patients, particularly with chronic pain from diabetic neuropathy that's been there for many months or many years, is I can't necessarily make the pain disappear. I can't necessarily make your pain go down to zero. And one of the scales we often use to have patients tell us how bad is your pain is the so-called numeric pain rating scale, from 0 being no pain to 10 being worst possible pain, as if there's a lit match on your foot. And let's say they come to me and they have a pain of 9/10, very bad, keeping them awake at night, bothering them all day long. I tell them, we're going to try to provide some treatments to you that are going to reduce that level of pain from a 9 to a 6 to a 3, some patients even to 1. 0 is unfortunately difficult, but we do our best to ratchet down the pain. And we have different types of treatments we can offer that we can discuss in terms of how we ratchet that pain down. And so what type of treatments do we have? Well, we have topical therapy that we actually put on the skin. Creams, gels, patches, we can talk more about that. We have oral medication, pills that we use. And we can talk about the different types of oral therapies. And then we even have interventional treatments, such as spinal cord stimulators in people with severe uncontrolled pain. In the topical category, of course, there are supplements over the counter, different creams in the health food store. Most of them actually don't have a lot of strong evidence of support. And I always caution patients not to spend or waste too much money on things that don't have a lot of evidence that they work. Vitamins, supplements, frankly, don't have a lot of support. Some people think vitamin E may help, even that's a little questionable. I do caution people against megavitamin use. B6 particularly, if one takes too much B6, it can actually harm nerves. I always want B12 to be looked at, because if the B12 is too low, that needs to be supplemented to bring that up to normal levels. But I don't have big faith in megavitamin use. Topicals, we talk about topical lidocaine, creams, gels, sprays, lidocaine patches, either prescription or over the counter. They're off-label, they don't have much evidence, but they're easy and relatively safe, and some people find benefit with lidocaine. Then we have another interesting topical, capsaicin. Now, capsaicin is the active substance of the hot chili pepper. And although it burns when you put a hot chili pepper in your mouth, it actually has pain relief properties. There are a very low concentration over-the-counter capsaicin creams. They burn a bit, they sting, they only last a very short time, and some people find them helpful, but in my experience, not very much. Over the last couple of years, there's now a prescription high concentration capsaicin patch, about that size. It's called Qutenza. And I was privileged to lead a large placebo-controlled study in diabetic neuropathy, showing that when one puts that patch on in the doctor's clinic on the feet for 30 minutes, then takes it off, there could be pain relief for 3 months. And it's a very interesting and very exciting medication. It's not that widely recognized by many doctors, but I am enthusiastic about its use, and it is FDA approved and reimbursed for diabetic neuropathy. We then have oral medications. Traditionally, the anti-seizure, anticonvulsants like gabapentin or Neurontin, pregabalin or Lyrica, and those are commonly used with some benefit. And then we have the antidepressants that also can help pain, the tricyclics like amitriptyline or Elavil, or what I like to use quite often, the SNRIs like duloxetine or Cymbalta. Those can be very effective as well. And then finally, you mentioned intervention like the spinal cord stimulator. This is a surgical procedure where a stimulator is put into the spinal canal, and it needs a neurosurgical procedure, but that for very severe pain in patients who failed many other things can be effective for relief. So that's a very brief overview of the treatments available.
It's great to hear that there's multiple treatment options for our patients, and to let them know that they're not just stuck at trying the cream. Because a lot of times patients will come in like, I already tried the capsaicin cream, I already tried this, it's not going to work. Let's not try that. Real recently, I've been using Qutenza as well in my clinic, and I've seen great changes for some of my patients. And I tell them, this is prescription strength. It's not a topical. It has to be in a controlled environment done by a physician, and it works. For a lot of my patients. So it's great to know that there's other options out there that more recently have come out, and also other things that we can do. Our last question, I'll kind of wrap it up here. What else do you want patients to know about diabetic peripheral neuropathy, or anything we talked about today?
Well, the one thing we didn't discuss is how common it is. And in patients with diabetes, depending on what studies one looks at, up to 30% or more of patients with diabetes type 1 or type 2 have neuropathy, and a significant number of them are painful. And I think, Nick, you and I mentioned earlier, patients do not need to accept living with this pain that's untreated and uncontrolled. And I strongly advise patients to advocate for themselves, do web searches, ask their physicians to get them or refer them to a doctor who has the type of knowledge as you and other experts have, so they can avail themselves of the best new advances in treatment.
Well, Dr. Simpson, thank you so much again for spending this afternoon with me discussing about diabetic peripheral neuropathy. Again, thank you all for tuning into this. And again, I'm Dr. Nicholas Butler with APMA Communications Committee, a young physician member, and also with the rest of the APMA. We thank you all for tuning in today. Thanks.
Thank you for having me, Nick.
Of course. Thank you.